Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullah. Today we're going to continue with talking about viral causes of respiratory infections. Last time we talked about influenza virus as a cause of mostly upper respiratory tract infection and could be a cause of, in certain instances, lower respiratory tract infections. Today we're going to continue with other viruses that might cause respiratory tract infections. We're going to talk about Paramyxoviridae, which are helical viruses, envelope viruses, which possess a negative sense, single-stranded genome, belongs to the RNA viruses. So, parainfluenza virus. Once we hear about parainfluenza virus, we're going to think about an age group which is 6 months to 4 years, and we're going to think of croup, or what's called laryngotracheobronchitis. So laryngotracheobronchitis or croup is always tied with parainfluenza viruses, especially serotypes 1 and 2, as we're going to see later on. So it's a single-stranded RNA virus, negative sense, envelope. And there are 4 serotypes, serotype 1, 2, 3, and 4. And 4 is further subdivided into A and B. There is no common group antigen, so antigens for serotype A are different than antigens for serotype 1, other than 2, 3, and 4. And it is closely related to mumps virus, which belongs to the same Paramyxoviridae family. Structure of parainfluenza virus. As you can remember, in the influenza virus, we said that there are 2 glycoproteins in the envelope. One is the H and the other is the N. Here in the Paramyxoviridae family, or the parainfluenza virus specifically, we can see that the H and the N come on the same glycoprotein. It's called hemagglutinin neuraminidase, and it plays a role in attachment and internalization of the virus into the target cell. We have also the F protein, or the fusion protein, as well, which plays a role in the fusion of the viral and cellular membranes together and in syncytia formations. Also, we have the matrix protein. Also, we have the nucleocapsid protein, the phosphoprotein, which are associated with the genome of the parainfluenza virus. The virus has a size which ranges from 150 to 300 nanometers in size. It is an envelope, and within the envelope we have 2 glycoproteins, the HN and the F protein. The HN is involved in the attachment to cell surface and entry, and thus heme adsorption and heme agglutination, which occurs as a result of this glycoprotein. And you need to familiarize yourself and remember what we said about the heme adsorption and heme agglutination and how to differentiate between them and what is each one of them. Also, we have the F protein, or the fusion protein, which helps in fusion of the host and the virus cellular membranes, and syncytia formation or multinucleated giant cell formation results from the F protein. M protein also plays a role in the assembly of the virus, and it guides the viral proteins and genome to exit the cell through this through a specific location in the cell. Humans are the main host for parainfluenza virus, And if the parainfluenza virus infect animals, most of the time the animals are asymptomatic. The parainfluenza virus can be grown in cell culture, especially in the HeLa and the Hep2 cell lines. Next, we're going to talk about the replication cycle of the human parainfluenza virus. Human parainfluenza virus has a negative sense genome. The replication process starts by the binding of the F protein of the parainfluenza virus, binding to its receptor on the target cell. Then a fusion step occurs where fusion of the viral membrane occurs via the cellular membrane, and the nucleocapsid enters into the cytoplasm of the target cell. The negative sense genome is complemented by the positive sense antigenome, which serves as an intermediate for the production of new negative sense genomes, and at the same time the RNA-dependent RNA polymerase is going to give a positive sense RNA, which serves as a messenger RNA, and this is going to be translated into the viral proteins. Then the newly formed viral proteins and the newly formed negative sense genome are going to be assembled into a new virus, and this virus is going to release to a bud and be released from the target cell. How does the parainfluenza virus lead to or causes pathogenesis in the respiratory tract infection once it infects children? Infection in the respiratory tract lead to secretion of high levels of cytokines such as the interferon, interleukin-2, interleukin-6, and tumor necrosis factor alpha. And these chemokines and inflammatory proteins are associated with the symptoms which are seen in parainfluenza virus infection. Also, it is thought that the virus elicits an IgE antibody response as a result of its presence in the respiratory tract, and this is going to lead to release of histamine in the trachea, and this is what makes the parainfluenza virus unique in causing the laryngotracheobronchitis, or what we call CRO. Human parainfluenza virus, it causes serious illness in children, especially those aged between 6 months and 4 years, and it is known by the age of 5 years. Most children, we're talking about 75% of children, would have seroconversion against parainfluenza virus 1. It has a short incubation period. We're talking about 1 to 7 days, with an average of 2 to 3 days. And we have 4 serotypes for the parainfluenza virus. Type 1 and type 2 are associated mostly with croup, acute croup or laryngotracheobronchitis, and it is seen mostly in the fall and the winter months. Also, we have types 3 and 4, which are associated with respiratory tract infection. When we talk about type 3, it might be associated with lower respiratory tract infection, especially in children below 1 year of age, such as bronchiolitis and pneumonia. Type 4 is most of the time asymptomatic or associated with mild upper respiratory tract infection, and type 4 is the least common type of parainfluenza viruses to cause infection. Clinical manifestation or clinical picture: how do the children present when infected with parainfluenza virus? As we said, parainfluenza virus is closely associated to croup or laryngotracheal bronchitis, and the children with croup present with loud barking cough. They are febrile, they have hoarseness of voice, and they have noisy breathing. All these are associated with the infection and inflammation and edema in the larynx, trachea, and bronchi. It's going to affect both the breathing and breathing airways, and the also the larynx, which is going to lead to hoarseness of voice. Other conditions also can be caused by parainfluenza virus, such as bronchiolitis, pneumonia, or flu-like tracheobronchitis, or coryza-like illness, which is rhinitis-like illness. The X-ray for the child who has croup is diagnostic or have a significant picture where we can see the steeple sign. So this represents the normal airway in a healthy child, and this represents the steeple sign where we can see there is narrowing of the airway in the X-ray, and it resembles the steeple of the church. How to diagnose parainfluenza virus? Mostly diagnosis is clinical. The child is going to be in the susceptible age group. We're talking about 6 months to 5 years. Also, the clinical presentation with fever, barking cough, hoarseness of voice, and inspiratory stridor is diagnostic. Also, the time of the year during the winter or the fall should give us a clue. Other types of investigation, such as detection of antigens or virus isolation or serology or PCR, are not used routinely for the diagnosis of parainfluenza virus infection. Treatment and prevention. How to treat for parainfluenza virus infection? There is no specific antiviral treatment available for parainfluenza virus. It was found that patients or children infected with parainfluenza virus type 3 might benefit from nebulized ribavirin or aerosolized ribavirin. Antibiotics are not required since this is a viral infection, but if secondary bacterial infection is suspected, so antibiotics might be necessary. Also, there is a role for corticosteroids in case there is breathing difficulty, because it's going to decrease the amount of inflammation and edema and increase the diameter of the airway, which gives a better chance for the child to breathe better. Severe cases of croup should be admitted to the hospital and placed on oxygen tents, and there is no specific vaccine available for parainfluenza virus. As with other respiratory tract infection, we can break the cycle of transmission, which is usually through aerosolized aerosols, which are generated as a result of coughing and sneezing, talking, or others, and we need to take care of hand washing to break the cycle of transmission. So this is for the parainfluenza virus. Another virus which belongs to the same Paramyxoviridae family is the human respiratory syncytial virus, which is an orthopneumovirus. As its names imply, respiratory syncytial virus, so it has the ability to form syncytia or multinucleated giant cell. The respiratory syncytial virus has a size of 120 to 200 nanometer in diameter. It's an envelope virus. It's a linear negative single-stranded RNA genome, and it belongs to the genus Pneumovirus of the Paramyxoviridae family. There are subgroups A and B, and they have monoclonal sera, which are specific for each group of them. And both subgroups circulate in the community at any one time, but mostly the infections are caused by serotype A. It causes epidemics each year during the winter months. And the genome for the respiratory syncytial virus is composed of 10 messenger RNAs, and each one of them codes for a specific protein. We have the viral envelope is composed of the F or fusion protein, the G or the attachment protein. Also, we have the SH, M, and M2 proteins, which are embedded within the viral envelope. Also, we have the nucleocapsid proteins, L, N, and P, which are associated with either the nucleic genome or the genome of the virus or the RNA-dependent RNA polymerase of the virus. Also, we have the non-structural protein 1 and 2, which plays a role in suppression of the host innate immunity by interfering with the interferon 1 function. So the respiratory syncytial virus comes in yearly epidemic, especially during the winter months, and it's present worldwide. It has an incubation period of 2 to 7 days. Transmission, direct contact, especially in the childcare facilities, where it gives a good chance of child-to-child transmission because of close proximity within this setting. It appears in the winter months, especially November through April. Subtype A is more severe and predominant in most outbreaks, and subtype B is mostly asymptomatic and infect most of the population. So subtype A is more severe and most outbreaks are associated with it. Infections with subtype B is mostly asymptomatic. Children who are aged 2 to 5 months are more susceptible to infection with respiratory syncytial virus, and in fact 60 to 70% of the newborn children would be infected with respiratory syncytial virus during their first year of life or during the respiratory syncytial virus season. By 2 years of age, most children will have had one or more respiratory syncytial virus. So it was found that 90 to 95% of children who get to age 2 years would have seroconversion against the respiratory syncytial virus. Infection with respiratory syncytial virus was seen to be more severe in boys and in those of low socioeconomic class. Reinfection with respiratory syncytial virus is common. Even children might get infected with respiratory syncytial virus within one season multiple times, or they might become infected with respiratory syncytial virus on multiple successive years. But infection with respiratory syncytial virus was shown to be less severe and takes the mild side on consecutive infections after that. Respiratory syncytial virus begins with the replication of the virus in the nasopharynx. Then it spreads to the small bronchial epithelium linings within the small airways within the lung, and then goes to the lower respiratory tract infection, where the infection can start in the lower respiratory tract within 1 to 3 days of infection in the oropharynx. If the infection reaches the lower respiratory tract, it's going to cause edema, increase mucus production, and eventually necrosis and regeneration of the epithelial cells. So when we say respiratory syncytial virus, it's going to lead to bronchiolitis and bronchopneumonia in children less than 1 year of age. This is as a result of this bronchiolitis and bronchopneumonia, there will be airway obstruction, air trapping, and increased airway resistance. What are the clinical manifestations in case there's infection with respiratory syncytial virus? Most common cause of severe lower respiratory tract disease in infants less than 1 year of age. It's responsible for 50 to 90% of bronchiolitis and 5 to 40% of bronchopneumonia cases in newborns or children below 1 year of age. And they are responsible for most of the hospital admissions for children below 1 year of age during the winter months. Other manifestations might include croup, so respiratory syncytial virus might cause croup in 10% of those children. In older children and adults, infection with respiratory syncytial virus is associated with very mild disease characterized by common cold-like symptoms. In the upper airway, it might lead to cough and rhinorrhea. 50% of those who are infected by the respiratory syncytial virus, there is a chance that they might also, the infection or the virus might get into the lower respiratory tract and cause bronchiolitis and bronchopneumonia. Bronchiolitis is characterized by fever, cough, runny nose, wheezing, and breathing problems. Also on the chest x-ray, we can see hyperinflation of the lungs. So the lungs are going to look larger because of the entrapment of air within the lungs and the narrowing of the airways. So the child is going to find it hard to exhale. As a result of that, we are going to see hyperinflation and we're going to see interstitial infiltrates within the lungs, which are indicative of pneumonia. All children are at risk of infection or are going to be infected with respiratory syncytial virus, especially during the first 2 years of life, but certain children have a higher chance of complication when infected with respiratory syncytial virus, especially those who have a congenital heart disease or who have a pulmonary disease, underlying pulmonary disease, or they are immunocompromised. In this case, the mortality rate is going to be raised up to 15% if they have any pre-existing conditions as the ones seen in here. And this is compared to the mortality rate of 0.5 to 1%, which is seen in the normal children. Respiratory syncytial virus immunity is not well understood, but it's known that both humoral immunity and cellular immunity play a role in immunity against respiratory syncytial virus. So the antibodies play a role in immunity, and also the CD4 and CD8 play a role in immunity against respiratory syncytial virus. No level of serum antibodies provide protection. it was found that even if you have seroconversion, if you have antibodies against respiratory syncytial virus, still there's a chance of being infected with respiratory syncytial virus, but the infection is going to be less severe and milder. Cell-mediated immunity also play a role, but the exact mechanism of immunity is not well understood. How to diagnose child with respiratory syncytial virus infection? We need to take a good history and do physical examination, and we need to think of the season or the winter season. As we said, most cases are seen between November and April. In the history, the mother might mention that her child has cough, he has wheezes, he has respiratory distress, and he might also have a fever as well. Physical examination could be another way to reach a diagnosis of bronchiolitis or bronchopneumonia. Also, the chest X-ray might show hyperexpansion. Also, following the blood gases, we might see hypoxemia or hypercapnia as a result of difficulty in breathing. In children and adults, signs and symptoms are non-specific, and the X-ray is not that helpful. What are the X-ray findings that can be found? As we said, hyperinflation, peribronchial thickening, increased interstitial marking, which is indicative of pneumonia and fluid within the lungs, and also consolidation and atelectasis of the lungs. Diagnosis of respiratory syncytial virus. Once again, as we said, history, physical examination, and chest X-ray might be helpful in most cases of respiratory syncytial virus infection. Very rarely we might need to use these sort of investigations such as fluorescent antibody or enzyme immunoassay or even PCR or tissue biopsy, and the serological tests are not that helpful in respiratory syncytial virus infection. So how to treat children with respiratory syncytial virus infection? The main management strategy are maintenance of hydration and oxygenation. So it's symptomatic treatment, but the most important part of it is keep the children hydrated and give them good oxygen supply. Bronchodilators might help expand the airways and make children breathe better. Corticosteroids also might decrease the inflammation and the edema associated with it, and they might be used and beneficial for those children. Also, we need to watch for bacteria superinfection on top of the viral infection, and it was seen that certain number of those who have respiratory syncytial virus infection might develop otitis media as a bacteria superinfection shortly after recovery from the viral infection. Aerosolized ribavirin might benefit those children who are immunocompromised and who have severe infection. It was found that giving a nebulized 3% hypertonic saline can reduce the hospital stay length. Why is that exactly? It's not really understood, but it was shown to reduce the hospital stay by 24 hours. Is there a vaccine for respiratory syncytial virus? No, there is no vaccine for respiratory syncytial virus, despite being working on that for a couple of years. But there is an immunoglobulin, which is palivizumab, which is directed against the respiratory syncytial virus F protein. It's not part of the routine treatment against respiratory syncytial virus since it is expensive. Next virus we're going to talk about today is the adenovirus. The adenovirus is a DNA virus. It is a naked virus. It has an icosahedral capsid and it is 70 to 90 nanometer in diameter. It's double-stranded DNA. It has a pentose base here, protein. Also, it has a pentose projections here, and these help the virus in attachment to target cells, and also they are toxic to the target cells as well. The adenovirus is a DNA virus, so it replicates in the nucleus, and there are more than 100 serotypes of the adenoviridae. 54 to 57 serotypes are known to cause disease in humans, and the adenoviruses are classified into 7 subgenera from A to G. The adenovirus, the name adenovirus came from the isolation of the virus from the adenoids of children after long periods of time after infection with the virus. It was found that the virus can still be isolated from the adenoids in the posterior to the nasal cavity of children 6 months to 18 months after the virus infection. So it's a DNA virus. It is characterized by latency as well. So as we said, it is isolated from the human adenoids. It was isolated first in the 1953. It has a pentose projections which are used for attachment via the Coxsackie adenovirus receptor on the target cell, and it is associated with toxicity as well. The adenovirus has tropism for cells of epithelial cell origin, so as we're going to see later, it is associated with clinical manifestations in multiple locations in the body, especially we're talking about respiratory tract infection, conjunctivitis, gastroenteritis, meningitis, cystitis. All these can be manifestations with the adenovirus. The adenovirus has developed certain mechanisms to evade the immune system in our bodies, and these mechanisms are there are multiple mechanisms. The virally associated RNA can inhibit interferon, so the first thing is interferon inhibition. Interferon, as we know, is released from the viral infected cell to warn neighboring cells that this cell is virally infected, so that it activates the interferon gene in order to activate the mechanism of getting rid of the infectious viruses. The second mechanism is the E1B protein can inhibit apoptosis. And when the virus inhibits the apoptotic mechanism of the cell, then it gives itself more time to replicate and produce new progeny viruses. The third mechanism is that the E3 gene codes for a protein that traps the host MHC in the endoplasmic reticulum. So there is a way for the immune system to recognize that this cell is virally infected by presenting the viral genes to the immune system via the major histocompatibility complex. But if the host major histocompatibility complex gets trapped inside the endoplasmic reticulum, then the antigen is not going to be presented on the surface of the cell, and then the immune system is not going to be able to know that this cell is infected with the virus. Also, the late genes of the adenovirus lyse the host cell by inhibiting macromolecular synthesis and the shuttling of host messenger RNA. How is that helpful? Because this helps in the release of the naked adenovirus and spreading to the neighboring cell and leading to infection of the neighboring cell as well. Clinical syndromes which are associated with adenovirus, it might cause pharyngitis, pharyngoconjunctivitis, respiratory disease, pneumonia, hemorrhagic cystitis, especially 11 and 21, gastroenteritis 40 and 41. It might lead to intussusception and meningitis as well. How to diagnose adenovirus infection? Clinical picture, first of all, it's seen especially during the winter months. And when we say adenovirus infection, we talk about infection of the upper respiratory tract, which also can be associated with conjunctivitis. So if we see a child which has flu-like symptoms with conjunctivitis, redness of the eye, then we should think first of the adenovirus as the causative microorganism. So history, physical examination, and then we can do CBC and see lymphocytosis. We can do culture for the virus. That's not a routine. Stool culture as well, not a routine. Just X-ray in case of pneumonia could be helpful as well. Other tests such as antigen detection, PCR, virus isolation, and serology can be used to identify the adenovirus infection, but they are usually not a routine since it's another virus which causes upper respiratory tract infection and it is associated with an acute illness, which does not necessitate doing all these investigations. Prevention and management. Is there a specific antiviral drug for adenovirus? No, there is no specific antiviral drug, but they found that cidofovir might be effective in certain cases. Is there a vaccine? Well, there is a vaccine. It's not for the general population. It's a vaccine which has serotypes 4 and 7, but this vaccine is reserved and is given only for early military recruits in the United States. What are the other preventive measures? As all other respiratory tract infection, hand washing and using gowns and gloves and trying to get rid of the virus by using heat and bleach. The last virus that we're going to talk about today is the common cold viruses. When we say common cold, we're talking about two viruses. The first one of them, and the one which causes most common cold symptoms during the winter months, is the rhinovirus. More than 50% of upper respiratory tract infections during the winter months are caused by rhinovirus, followed by influenza virus, followed by coronavirus. Both rhinovirus and coronaviruses are labeled as common cold viruses. Other upper respiratory tract infection can be caused by other viruses such as the adenovirus, the enterovirus, the respiratory syncytial virus, influenza, parainfluenza viruses. So the rhinovirus is the most important cause of the common cold and upper respiratory tract infection. Rhinovirus has more than 100 serotypes. Nowadays we're talking about almost 160 serotypes have been identified for rhinoviruses. The rhinovirus, there are more than 160 antigenic types, belongs to the Picornaviridae family, which is a naked virus with icosahedral capsid. And as we said, all naked viruses have icosahedral capsid, and it possesses a single-stranded positive sense RNA. Within the Picornaviridae family, there are other genuses such as the enteroviruses, which are viruses which are transmitted through the GI tract, through the fecal-oral route. Also, we have the hepatovirus, which is the virus responsible for hepatitis A virus infection within the Picornaviridae family. The rhinovirus is a single-stranded positive sense RNA virus, belong to the Picornaviridae family. It's a small virus, 20 to 30 nanometer in diameter, icosahedral and naked. We're talking about 160 serotypes, which are divided into 3 species, A, B, and C, and the capsid contain 4 proteins, VP1, 2, 4. Picornaviridae, as we said, have the enterovirus and have the rhinovirus. Enteroviruses are transmitted through the fecal-oral route, but the rhinovirus is unable to replicate in the GI tract. The primary route of entry for human rhinovirus is the upper respiratory tract, especially the mouth and nose, through aerosols and fomites. The rhinovirus prefers to live and replicate within the nasal cavity, where the temperature there is around 33-34, which is the preferred temperature for replication of the virus. And it uses the intracellular adhesion molecule 1, or the ICAM 1, for attachment and entry into the target cell. And the severity of the infection is associated with the quantity or titer of the virus that has been inserted or that has reached into the nasal cavity. Incubation period is somehow minimal. We're talking about 2 to 3 days, and symptoms are mostly runny nose, coughing, sneezing, nasal congestion, and 24 to 48 hours later might be followed by sore throat. There are some infrequent symptoms such as general fatigue, malaise, headache, muscle weakness, or loss of appetite, but these are not the regular symptoms seen in infections with rhinovirus. The rhinorrhea increase and is often accompanied by symptoms of nasal obstruction. These symptoms happen as a result of increased levels of bradykinin. Bradykinin increase secretion and lead to vasodilatation, and as a result, this leads to congestion and sore throat. Infection with rhinovirus can be associated also with headache, malaise, and chills as a result of the temperature. The illness lasts 3 to 4 days, or peaks within 3 to 4 days and finish in 7 days mostly. Diagnosis, it is mostly a clinical diagnosis, and we very rarely need to refer to these diagnostic tools to diagnose infection with rhinovirus. Is there a specific antiviral drug. No, there is no specific antiviral drug for rhinovirus treatment in all respiratory tract infection by viruses is symptomatic treatment. There is no vaccine for the rhinovirus. As we said, we have more than 160 serotypes, and the virus continually introduce mutation and new subtypes emerge, so makes the production of a vaccine against it a difficult task. Some treatment modalities are, as we said, it uses the ICAM1 for entry into the target cell. So antibodies that are directed at the virus receptor or a recombinant soluble receptor ICAM as a drug can be given so that it blocks the glycoprotein of the virus and prevent it from binding to the ICAM of the target cell is one treatment modality. Also, there is the IMP 1088 is an enzyme inhibitor of the human N meristyltransferase and MT1 and MT2 capable of preventing rhinovirus replication. This is a new drug, and both the ICAM1 soluble receptor and the IMP 1088, they are not used routinely to treat, but as we said, the symptomatic treatment is the way to go in the case of rhinovirus infection. Prevention, once again, hand hygiene is an important measure to control the infection. Then the next 3 slides shows tables where a comparison of the viral causes of respiratory tract infections, especially we're talking about adenovirus, rhinovirus, orthomyxovirus, and coronaviruses. Coronavirus is another virus which causes common cold, but for its importance nowadays, I'm going to talk about coronavirus infections in a separate small section or lecture, which is going to be part 2 of lecture 5, in order to cover the hot topic nowadays, which is the new coronavirus, which is the coronavirus, the SARS coronavirus 2, which causes COVID-19. These tables compare these respiratory tract viruses in terms of envelope, in terms of their structure, whether they are DNA or RNA viruses, and the size of the virus particle, the antigenic structure, the cellular tropism for these viruses, and do these viruses cause local or systemic infection. Also, the isolation of the viruses in the cell culture. What are the treatment modalities? What are the most important features that we need to know about these viruses? And is there a vaccine available for each one of these viruses or not? Also, what is so unique about these viruses that might lead and become more infectious and a threat to the humans if they infected them? Also, what is unique about their infections? So that's our lecture for today. We're going to continue with a small lecture about coronavirus, which is going to be linked to this lecture as lecture 5 part 2. Thank you for listening.